thank you for joining us. We have Alyssa, Leah, Amber, and Jen. Our group has conducted an evidence-based practice analysis titled Children and Adolescents in Foster Care and the Risk of Developing Substance Use Disorders. This is a topic of critical importance to our field. We are examining how involvement in the welfare system intersects with the underlying factors that contribute to the development of substance misuse. Our goal today is to synthesize the current research to understand whether young people entering foster care are more likely to develop substance use disorders than their peers, and if so, what mechanisms drive that risk. We need to start by understanding the population. Children entering the foster care system represent one of the most vulnerable demographic groups in the United States. We know from data provided by Adopt US Kids that thousands of children enter this system annually. It is crucial to recognize that their entry into care is rarely a neutral use or community violence. The core issue we are examining is that the exposure to these specific adverse circumstances does more than just displace a child physically. It significantly increases the likelihood of long-term emotional and behavioral challenges. Specifically, our analysis points to a markedly higher prevalence of substance use disorders, or SUDs, during adolescence and young adulthood for these youth compared to peers who have not experienced placement. So, what is this mechanism behind this? Why does placement correlate with substance use? To explain this, we utilize the framework of adverse childhood experiences, or ACEs. Research consistently demonstrates a strong correlation between foster care placement and unusually high levels of ACEs. When we talk about ACEs in this context, we aren't just talking about a single event. We are looking at a combination of trauma exposure, physical abuse, neglect, household dysfunction, community violence. For a child in the system, these factors often stack on top of one another. They might experience caregiver substance use at home, followed by the trauma of family separation, followed by placement instability. The statistical reality of this trauma load is alarming. We looked at legislative testimony and long-term studies, specifically the work of Courtney. Their data reveals that approximately 80% of the youth in the foster care experience 4 or more ACEs. I want to pause at that number, 80%. In the general population, a score of 4 or more is considered high risk and relatively rare. In the foster care population, it is the norm. This includes not just abuse, but exposure to community violence, household dysfunction. This data serves as the foundation for our entire analysis. We are dealing with a population that's starting from a baseline of severe cumulative trauma.
Thank you. I want to pick up exactly where Alyssa led off. Regarding that 4 or more ACEs threshold, we refer to this as the multiplier effect. When we look at CDC data comparing risk likelihood, the disparity is stark. For individuals with 4 or more ACEs, which, as we just established, includes 80% of foster youth, the risk of developing an alcohol use disorder is 7 times higher than the baseline. Even more concerning, they are 12 times more likely to engage in illegal drug use because of the trauma they've experienced. Even before considering things like genetics or environment, these children are already at a higher risk for developing substance use problems. To analyze this clinically, we must be precise about our definitions. We are using the DSM-5 criteria for substance use disorder. It is important to distinguish between experimental use and a disorder. A disorder is characterized by impaired control, meaning compulsive use using in physically hazardous situations. And finally, physiological signs like tolerance and withdrawal. For foster youth, who often suffer from disrupted attachments and emotional dysregulation, the path from experimentation to meeting these full diagnostic criteria is much shorter than it is for their peers. In our research, we categorize the drivers for these disorders into two main areas: external and internal risk factors. External factors are environmental. Hanley highlights factors like community violence and living in unsafe neighborhoods. Crucially, we point to unconventional peers, association with friends who are already engaging in risky behaviors. For foster youth, a lack of consistent monitoring by caregivers can exacerbate their peer influence. Internal factors, on the other hand, relate to psychological coping. Gabrielli et al. Found that the style of coping matters immensely. They distinguish between problem-focused coping, which decreases risk, and emotion-focused coping, which increases it. Emotion-focused coping essentially means attempting to reduce negative emotions immediately, often by numbing the pain. This finding is critical because it tells us that for many foster youth, substance use is not just bad behavior. It's a maladaptive survival mechanism to deal with overwhelming emotional pain.
Thank you. Moving on to the structural contributions, we examined the impact of instability itself. We reviewed a quantitative study by Moss et al., which is particularly strong because it used a nationally representative sample. This study specifically examined developmental pathways linking childhood adversity to substance use disorders. Their key finding was startling. Youth who experienced both foster care placement and homelessness exhibited remarkably higher rates of substance use disorders. Specifically, they found a 50 to 70% higher risk of developing an SUD by early adulthood compared to peers without these experiences. This highlights that housing instability acts as a massive compounding factor. The study essentially concluded that homelessness should be viewed as a severe adverse childhood experience in its own right. If we visualize this, we see a developmental trajectory of risk. The risk is accumulation over developmental stages. As a child moves from childhood into adolescence and young adulthood, the gap between them and the general population widens. Interestingly, the Moss et al. Study tested the hypothesis that foster care might act as a protective factor, meaning perhaps being removed from a bad home would lower risk. However, this hypothesis was not supported. This indicates that the placement itself is not enough to mitigate the trauma if the underlying instability and ACEs are not addressed. Despite this overwhelming evidence of high risk, the 80% ACEs rate, the 12 times higher drug risk, our current systems are failing to identify these youth early enough. Grenier et al. Highlighted a critical gap in our standard of care. Currently, less than 30% of children in the foster care system are subject to regular substance use screenings. Just think about that. We know that this is a high-risk population, yet 70% are not being screened. The consequence of this is that we are missing the opportunity and effectively waiting for behaviors to escalate into full-blown disorders before we act, rather than utilizing evidence-based practice screening models like SBIRT to identify emerging patterns.
So now that we have talked about the problem and the gaps in the systems, let's look at what actually works. Our research highlighted evidence-based interventions that have shown real success. The first is trauma-informed cognitive behavior therapy. This is important because it helps youth work through their trauma history and change those emotional focus coping patterns that Amber talked about earlier. Second is the screening, brief, intervention, and referral to treatment. This model helps fix the screening gap we mentioned earlier. It is very effective for catching problems early. Third, we have family-centered interventions. These approaches focus on stabilizing placement and strengthening relationships with caregivers. When placements are stable, it reduces the risk that comes from poor supervision or hectic home environments. And finally, mentoring. Having a supportive adult who shows up constantly can make a huge difference. Strong mentoring relationships can help youth build emotional skills, confidence, and resilience. For us, future social workers, this research has major implications for how we practice. We look at this through two levels, meso and micro. At the meso level, our role is to coordinate and support. We work directly with foster families, schools, and community programs. Our job is to strengthen communication between these groups, help foster parents and teachers stay on the same page, and make sure tools they need to support the children. At the micro level, our role is advocacy and policy change. Following the NSW Code of Ethics and our core value, social justice. We have to push for better systems. This includes advocating for policies that require screenings so we can close that 30% screening gap, and fighting for funding and supporting prevention, treatment, and aftercare programs.
Thank you, Jen. In closing, the evidence is clear. Children in foster care face higher than average risks for developing substance use disorders. This comes from high exposure to trauma, repeated instability, and lack of consistent support. But the future isn't predetermined. Research shows that with early screening, trauma-informed care, stable relationships, and a strong support system, we can lower these risks in meaningful ways. As social workers, we are in a position to create real change. We can help these young people find stability, healing, and a healthier path forward. Here are some of our references. Our analysis was supported by data from the Center for Disease Control, long-term studies by Courtney et al., and Moss. Treatment guidelines were provided by NIDA and SAMHS. Thank you for all your time and attention. We're happy to answer any questions that you might have. Thank you for listening.